syndrome is real and has been puzzling the dental and medical professions for decades. This is the TMJ TMD Demystified podcast with Dr. Tony Urbanek, where we'll connect the dots between TMD symptoms and the actual cause. We'll tackle common TMD misconceptions and educate you, the practitioner, about a simple, tested, and proven TMD solution that has already provided relief to thousands of patients, while helping practitioners build an additional source of income free from insurance control. Welcome to this episode of the TMJ TMD Demystified podcast.
Hi, everyone. Welcome to the next episode of TMD Demystified live stream. It's Saturday noon, the 8th of August, 2026. I am Tony Urbanek, and we are gathered here. We are here to find out more about TMD Demystified, more about temporomandibular joint disorder. Up until this time, a complete conundrum within the dental and medical establishment. Complete conundrum. Not by design, but I must say by ignorance. Ignorance is not necessarily a pejorative. Ignorance just means lack of knowledge. Ignorance without knowledge. So I have taken it upon myself to fill in the gap, to put the knowledge there to both the doctors, dentists and physicians, and physician associates, dental associates, but especially patients. And that is the reason that in addition to my weekly podcast, which is seen on Dental Town and YouTube and other places, and a weekly blog, which is written every Sunday night and published Monday morning in various places, especially our website, but published to all of our current and past patients and network providers, that is, doctors who use the same methods and materials that I use to solve and my practice uses to solve temporomandibular joint disorder. In addition to that, I have decided to do a live stream giving patients, particularly patients, but also doctors, the ability to communicate with me, ask questions, make comments, and if they'd like, criticize. But please remember, doctors, if you'd like to criticize or question, I will answer directly. I will not avoid any questions or criticism, but make sure that you bring your science with you and that you define your terms. A tribute to Voltaire: if you are to argue or if you are to communicate with me, you must first define your terms. So today's topic is entitled Changing Paradigm and TMD. Changing the paradigm and TMD. There's an old paradigm and there needs to be a new paradigm. The old paradigm is not working. It has not worked for the past 60 years. It's still not working. It is making some people, especially drug companies, pretty wealthy, but it's not working for the patients. And that is why I do this. I do this for the patients. I do this for the millions, and I don't exaggerate anything I say, the millions of women just in the United States of America who have this problem and have been run around in circles trying to find a long-term solution. Long-term solution. And there is a long-term solution for this problem. We'll talk about that sometime in the next 30 minutes. I always include it. But patients need to know that I know that they've been run around in circles because we see it in our clinic, in our practice every day, not occasionally, not once a week. Patients who have been seen by 2, 4, 6, 8, 10. One patient said 150 doctors over 10 years. She says, you must believe me. Over 10 years, I have seen 150 doctors trying to figure out and help me with all of these disparate symptoms that I constantly have. The disparate symptoms of temporomandibular joint disorder, the more common disparate symptoms, there are some more unusual ones, but the most common ones, totally agreed upon, are frequent or recurring headache, earache, jaw pain, neck pain, ringing in the ears, tinnitus, that's called tinnitus, not tinnitus, fullness in the ears, which is really subjective hearing loss. You have the mechanisms are working well. You just can't hear well because it feels like the ear's full of water. Dizziness, vertigo, which are two separate kinds of symptoms. They're similar as that you feel dizzy, but one is an internal and one is an external type of dizziness, like the whole room is spinning or you're spinning, dizziness or vertigo. Upper back or shoulder pain, upper back and shoulder pain, arm, hand, finger tingling and numbness or pain, and various kinds of jaw locking. Those are the well-known symptoms associated with temporomandibular joint disorder. Any dentist who allows himself to see these patients knows that those are the patient's complaints. Maybe you don't have all of them, but 45% of females in the United States are bothered by one or more of those symptoms. Most of them have 3, 4, 5, 6 of those symptoms going on simultaneously, recurrently. They're recurring symptoms. They get better and they go away, and they get worse and then they go away. They get worse and they go away. Every time they come back, they get worse. That is the story of TMD, a conundrum of symptoms poorly understood until this time, and I've taken it my responsibility to explain it to my colleagues and the general public to cut out the nonsense as far as treating this disease with smoke and mirrors and voodoo by what I term TMD gurus who use smoke and mirror and voodoo, mainly trying to treat symptoms without even understanding the disease and understanding what the causal reasons are and how the mechanism works within the body to create all these disparate symptoms. Frankly, that is what I figured out. That is what I discovered in the literature. I did not have to do any whole cloth science to create this information. The information has already been out in the literature for the better part of 70 years, some of it going back over 100 years. I was able to connect the dots, explain how you can get each and every one of those symptoms directly from, caused by, directly, inflammation within the temporomandibular joint. Creates headache, earache, jaw pain, etc., all the way to the end of that symptom list. So we have a current paradigm which is not working, which is creating a situation where patients, primarily females, 90% females, 10% males, are run around in circles between doctors, between clinics, misdiagnosed all the time, and sometimes goes on for many decades, not just 10 years. I have many patients, 20 years, 30 years, a few of them 40 years of being run around between doctor and being placed on medication and having all kinds of things done to them, at very best only work short time, and the symptoms then return. Why? Because the doctors don't understand the disease. So I am not going to go through that again. If you would like to know exactly the mechanism, how chronic inflammation, this is the biomechanical pathophysiology, cell biology, neuroanatomy, gross anatomy, explanation of how chronic inflammation creates all these symptoms, please refer to many of my prior episodes, especially the podcasts, but also located on the blogs that I write, which you can see on www.urbanektmj.com. If you want to review any of the 264 podcasts, you can go to Dental Town, and anybody can get access to that, whether you're a dentist or not, or you can see them on YouTube. But today we want to just emphasize and talk about the paradigm and the new paradigm, which needs to be there. That is my mission. That is my job. I am not going to stop. A lot of doctors would like me to stop talking about this because it makes them look bad, unfortunately. I respect my colleagues, I have to say. Let me just chime in here with a comment. I respect each and every one of my colleagues because I know what each and every one of them, whether they went through dental school or medical school, and I went through both dental school and medical school, and a degree in cell biology and anatomy. And additionally, was a fellow with the National Institute of Health for 2 years with my own research project on facial growth and development. So I also understand my academic colleagues. So all three categories, my medical colleagues, my dental colleagues, and I can honestly say my academic colleagues, I understand what you did to get there, the amount of work you had to do, the amount of dedication, the amount of time and money that you spent on your education. I admire you for it. So I am not trying to detract from who you are, but I am allowed to detract from what you've done. So if you are a doctor of any kind who needs more information so that you are not ignorant without knowledge, remember, ignorant without knowledge, I am here to help because that's my job, to help patients primarily, and now to help my colleagues. So the current paradigm is no different than it has been for the past 50 years. In 1972, in my third year of dental school, I was invited along with several of my third-year colleagues at Indiana University School of Dentistry, good school of dentistry. I finished that dental education knowing that I knew how to do dentistry. I felt very confident I'd come out and I could drill and fill and make crowns and dentures, and I knew that was able to do it. Now that was not enough for me, and I decided that maxillofacial surgery reconstruction was what I wanted to do, and then I went on a course to do that, and I did that for 50 years. But back in 1972, myself and five of my third-year dental student colleagues were invited to go and participate in the dental medicine clinic at Indiana University School of Dentistry. At the time, I didn't know what the dental medicine clinic, that was what it was named, was all about. I was soon to find out. But when we showed up at the appropriate room, there was a professor in there, a young professor, as it turned out, who took responsibility for the dental medicine clinic. And he explained to us at the beginning of the clinic that we were going to see 3 patients, all of them having what he described with symptoms as TMJ. Now, let me define. TMJ is the name of the joint. I know all my dental and physician colleagues know that. But the universe calls this problem of jaw joint problem TMJ. Why they do that, I'm not really sure. It's like going to the orthopedic surgeon and announcing you have knees. But everyone, including the doctors, call problems with this joint TMJ, which is the name of the joint. The more accurate name would be temporomandibular joint disorder, which is, by the way, to emphasize one disorder. It has multiple symptoms, but only one disorder, which is chronic inflammation within the temporomandibular joint. So I was at this clinic as a young dental student wanting to learn. And so the professor invited sequentially each one of these 3 patients in, not at the same time. He interviewed them sequentially, independently, collected their symptoms, did a good job of investigation, collected their symptoms, got some x-rays. We looked at the x-rays, did an examination, intraoral examination, extraoral examination, found out where there were painful parts, whether it would hurt in the mouth, external to the mouth. Spent a lot of time with a stethoscope listening to joint noises. I couldn't quite really understand the importance of that, but that seemed to be an important thing. And then each sequential patient then certainly had symptoms of that symptom list that I just reeled off a minute or two ago, and then announced to the patient that they had TMJ and prescribed nonsteroidal anti-inflammatory drugs. At the time, I'm not sure whether, I don't think he used aspirin. Ibuprofen, I believe, is what he prescribed, even way back in 72. And a night guard. A night guard. Now, this is a night guard. A night guard is a device that you put in your mouth. Very commonly prescribed by dentists for patients who brux their teeth. Bruxism is the technical word for clenching and grinding. Now, this is actually a night guard that was produced by a well-known dental lab here in the United States of America, which covers the surfaces of the teeth so that when you do clench or grind, you can't damage your teeth. And it is well known that people can crack fillings, they can crack teeth, you can crack a tooth right down the middle if you put enough force on it and long enough with clenching and grinding with bruxism. So he prescribed nonsteroidal anti-inflammatories and a night guard for each one of the patients in sequence. The first one, same thing. He did the history, he did the examination, we looked at x-rays, he announced they had TMJ, and then he prescribed anti-inflammatory and a night guard. When he was finished, I was quiet, as I usually was in dental school. I figured out in dental school the proper thing to do is pay attention, keep my eyes open and my mouth shut. Several of my colleagues had a few questions during his examination. I did not have any, but I waited till the patients were out of hearing. The last patient had left and all the patients were out of hearing view, hearing what was going on. And I asked him this question: how does a night guard correct inflammation within the temporomandibular joint? Because he had agreed that there was inflammation in the joint. If you push on a joint and it hurts, you know it's inflamed. In fact, the proper way to diagnose TMD is to stand next to the patient, have them open widely, press firmly your fingers in the little depression where the condyle comes out of the fossa, and have them close rapidly, have the patient close rapidly. If the joint's inflamed, they will say ouch, or they'll respond. It will hurt. You've made your diagnosis. And this particular professor agreed that the joints are inflamed. That's why he prescribed nonsteroidal anti-inflammatories and a night guard. And I asked him very naively, very naively, how does a night guard decrease inflammation within the temporomandibular joint? Obviously, isn't that a reasonable question, even for a naive third-year dental student? And his response did not make any sense to me. He attempted a response, but it had no bearing on science. It had no bearing on what I had studied for 2 years prior, the anatomy, physiology, biochemistry of the body, because all dentists go through the first 2 years of their career studying basic sciences. They're let loose a little bit in your second year, but you're let loose. You spend most of your time in the clinics in your third and fourth year. Your first 2 years in dental school are very, very heavily on the basic science, just like medical doctors, to understand how the body works, which I enjoyed and really took to very strongly. first 2 years of my dental career. So I was well versed at all the basic sciences, and what he said in response had nothing to do with any of the basic sciences that I had learned the prior 2 years. What he did say to me sounded like word salad. It made no sense, word salad. So I decided at the time, by the time I just kept my mouth shut, I certainly didn't argue with the professor, that there was something fishy about this thing called TMJ. And 55 years later, after 50 years of oral and maxillofacial surgery, and most of it having to do with facial reconstruction of many features of the face, the skeleton of the face, the intraoral cleft lip, cleft palate, all kinds of course, dental implants is kind of an office procedure, microneural surgery, orthognathic surgery, basically changing someone's skeleton around, and then a tremendous amount of temporomandibular joint surgery, over 2,000 cases of temporomandibular joint surgery I performed in those 50 years. And of course, the story is, I've said many times, 15 years ago, I decided TMJ surgery was not going to be the solution, long-term solution to this problem. Did the research and figured out how to treat this problem non-surgically. Successfully. By doing what? Making the inflammation go away by unloading the joint with a simple device and protocol. You just don't use this little thing. It's a tool to use. You use the tool correctly, you'll get the response. What you're doing is unloading the joint long enough in a way that allows the inflammation in the temporomandibular joint to decrease. As we discussed, the inflammation directly creates each and every one of these symptoms. If you make the inflammation go away, the symptoms will go away. Obvious, simple. So, I'm watching my computer. I haven't seen any questions yet. Maybe some of my medical dental colleagues don't dare challenge me. I don't know. Still waiting for a patient to make a comment or a question. We'll see by the end of this presentation here, which is only going to be another 10 minutes at most. So after 55 years of treating the temporomandibular joint, 36 of it surgically, and the last 15 or so years non-surgically, here are some undisputed facts regarding TMD in 2026. 50% of dentists prescribe a night guard to treat TMD but can't explain how it is supposed to work. The other 49.9% of dentists don't want anything to do with TMD because they think it's a complicated disease. They're taught in dental school it's a complicated disease, that this joint is different than any other joint in the body, which is not true. You'd never be able to figure it out if you completely think that this joint is different. All the joints work alike. And as I said, 0.1% of dentists try to treat TMD symptoms only and consider each symptom a separate disease, which is foolish. But that's what they're doing. A small percent of dentists want to do that. The medical doctors constantly confuse migraine headaches with TMD. We don't know what percentage, but the medical doctors admit they don't understand and they do not know what causes migraine headaches. Bad headaches for sure. But we get bad headaches from temporomandibular joint inflation, creating bad headaches. So what percentage actually are, quote, migraines, which the medical doctors can't explain, and TMD headaches, which we can explain and make go away by decreasing inflammation in the joint. The ENT physicians admit they have no treatment for Meniere's disease, which is defined as those three non-painful symptoms: tinnitus, ringing in the ears, subjective hearing loss, feeling of fullness in the ears, and dizziness. That is what they call Meniere's disease, which they have no solution for. If you go into an ENT doctor, get your ears examined, go to the audiologist, say, we can't find anything wrong with your hearing mechanism. and the patient says, I'm telling you, I can't hear out of this ear. That's what we call subjective hearing loss. You will go through a very extensive, very expensive, probably including an MRI examination, trying to figure out why you have those symptoms, at which point, if they say you have Meniere's disease, the patient will say, what can we do? And the doctor will say, we don't have a solution for Meniere's disease, but we know, we have done it over 5,000 times. By decreasing the inflammation in the joint, those symptoms, tinnitus, subjective hearing loss, and vertigo, diminish and go away. Spoiler alert, though, tinnitus is always the last symptom to go away. Tinnitus can take a long time. Don't be in a hurry with the tinnitus symptoms. Fullness, dizziness, usually within a month or two. And earaches, confused constantly with ear infection. You go to a walk-in clinic, convenient care clinic with earaches, and you're going to walk out with a prescription for antibiotic 100% of the time. And the walk-in clinic ladies, physician assistant, nurse practitioners, they don't bother doing this. If they did, they'd say, oh my God, your joint is inflamed. This must be temporomandibular joint disease, disorder, or maybe they'll just say this is TMJ. And then the person will say, what do you do for that? And they will say, go see your dentist. So you know what happens when you go see your dentist? 50% of the time you are going to get one of these. 49.9% of the time you're going to say, I don't do that. I don't want to do that. That's a complicated disease. And then 0.1% of 1%, they call themselves TMJ specialists. And ADA even made a specialty out of it. It's the biggest, it's the silliest thing the ADA has done in the past 30 years, since the time they were trying to convince all of us that amalgams were 100% safe, and that the material within the amalgam was 100% safe, which it isn't. And now they have a specialty on facial pain, which is connected to all of the doctors who want to treat symptoms. So, treating the cause by unloading the temporomandibular joint is the proper way. The current proper paradigm should be the current paradigm for treating this problem. Why do doctors not want to change the paradigm? Is because they have too much invested in the status quo. My physician colleagues have too much invested in pharmacopoeia. The big pharma has too many dollars invested in migraine headaches that they cannot define what causes a migraine headache. They basically throw drugs at the wall to see whether they will stick. I'm sorry, that's the truth. My ENT colleagues, remember, I respect all of my colleagues. I know what you all had to go through to get there. I did it twice. And, but my ENT colleagues have too much invested in Meniere's disease, doing that very complicated set of examinations and studies, and then announcing to the patient that there is no solution for Meniere's disease. And then finally, the convenient care clinics who are inhabited by nurse practitioners and physician's assistants who don't have enough experience looking at external artery canals at the ears, at the tympanic membrane, to distinguish from a real ear infection, because you can have ear infections that cause ear pain, for sure, and no ear infection, at which point, well, it must be something else. Well, maybe, let's see if it's TMD. Oh, your joints are hot, your joints are inflamed, you have TMJ. At which point, what will they say? They will say, go see your dentist, at which point we go through that circle again. You either get a night guard, or you get nothing, or you get your symptoms treated, which are only temporary at best, and hopefully not damaging, like many of the side effects of the medications that are prescribed for this. So I'm familiar with the problem. I'm familiar with why and how the paradigm is protected. The paradigm is very hard to change a paradigm, but the new paradigm should be, paradigm for TMD is chronic inflammation in the joint. What can we do to make the chronic inflammation go away? Rest the joint by unloading the joint, just like you'd unload a knee with a set of crutches. If you don't want surgery on your knee, the doctor will give you a set of crutches and say, if you stay on the crutches, your knee pain's going to go away, and it would. If you have tennis elbow, which is inflammation which is pain of the forearm, where the muscles pull on the nociceptors of the bone of the forearm, tennis elbow is inflammation of the lateral epicondyle. Going through that pathophysiology, please refer to one of my prior episodes. But tennis elbow is actually the same disease as TMD. Exactly the same mechanism, exact mechanism. The muscles get tight. The mechanism says get tight. They pull on the bone. The nociceptors, painful receptors, are stimulated, which registers back in the brain as pain. That is the mechanism for TMD, and the paradigm needs to be changed. And the reason it's not changed is the current professors and providers and professions have too much to lose. They have too much to lose with changing the status quo. This is not the first time in history anyone has dealt with this. It goes back a long way. They put Galileo on house arrest for the rest of his life when he said the Earth is not the center of the universe. So far, no one has tried to put me in cuffs. That's a quote from my blog, which I wrote last Sunday night and published. That is the current situation. I'm not worried about being put in cuffs. I'm going to speak out. I'm going to bring this to everyone's attention because the patients need it. The 45% of females who are running around in circles about this problem need it. They don't need to be misdiagnosed. They don't need to be running circles for decades. There is a solution to the problem. It's very simple. The protocol is very simple, 24/7 for 2 months and nighttime only the rest of your life. You can speak with it. You can obviously swallow with it. You can drink with it in your mouth. You just can't chew with it in your mouth. When you go to chew, you have to take it out of your mouth. After you eat, you brush it with toothbrush, toothpaste only, put it back in your mouth. Do the protocol 24/7 for 2 months, then nighttime, sleep time, nap time, the rest of your life. That is the solution. Okay, with that said, I appreciate your attendance. I have a couple comments here. Let's see what we have. Think I've had blank since May last year, hoping it will go away eventually, but worried about it. No, it's not going to go away. It may go away temporarily. This problem is ups and downs. That's because inflammation has ups and downs. Inflammation is cyclical. Inflammation goes up, you bring on symptoms. Naturally, the inflammation goes down for a while, then it goes up. Whether you treat it with drugs or whether or not you're treating it with drugs, it's still cyclical. Another question from Ben Cousins: is it consistent pain? Well, I just covered that. It got better in a couple of months, but since I quit my job and I'm looking for new work, it has got worse. Obviously, because if you quit your job and now you're without income, and that increases the stress. By the way, the only thing we know about temporomandibular joint disorder and about, what we know about bruxism, clenching or grinding, is that it's related to stress. We don't know the mechanism for clenching or grinding. We know it happens in the brain, but how does worry, anxiety, stress create bruxism? We don't know the mechanism. All we know, it is related to stress. So Ben, you're increasing your stress, you're increasing your bruxism. All right, so he's continuing with this. So what should I do? So Ben, You can go on our website and you can find a doctor if you're not in Middle Tennessee, which I assume you're not. You can go on our website, www.urbaniktmj.com, and you can see the doctors now in 20 states who are licensed to do this device and protocol, monitor you through it. It's pretty easy, but you need a doctor to provide the service. There are a few nuances that need to be known, and make sure that you do the protocol right and done correctly. So we have on our website the list of dentists. You have to be a dentist and oral maxillofacial surgeon, general dentist, who are licensed to do this, because this device and protocol is patented. You have to be licensed to do this. So you can go on our website, www.urbanek, U-R-B-A-N-E-K, TMJ, Tango Mike Juliet.com, urbaniktmj.com. All right. We have Victoria. We're getting some nice questions. Victoria says, I've had 2 gold teeth that were, I'm not sure. I've had 2 gold teeth. What does gold teeth have to do with TMD? I'm not sure I can help you. I've had 2 gold teeth that were hot. Well, that may be a dental problem. If you have a gold tooth, the tooth is hurting, you probably have something wrong with that tooth. Maybe that crown, that gold crown, actually had decay underneath it. So Ben back at me says, so if I rest it and keep soft diet, will it help? Well, yeah, it'll help, but it's not going to make it go away. Because you are going to continue to clench or grind. There is no on and off switch for clenching or grinding. There is no, if you are a clencher and grinder, if you're a bruxism, you're going to do it. And half the population, you got a lot of company. Half the population clenches and grinds their teeth. And we don't know the mechanism, and everybody has stress. So, half the population under stress will clench and grind. By the way, this goes back a long way. I investigated. There are 17 portions or statements within the Bible. Some of them in the Old Testament and some of them in the New Testament, talking about clenching and grinding the teeth. So let me see if anyone else would like to ask questions. Mercury from the 70s, and will I recover? It took TMJ cone x-ray to see all of the damage. Not sure the question, Victoria. And will I ever recover? Well, yeah, from the 70s, the mercury, it does stay in the body a long time. And the mercury in the amalgams, it was learned, but the ADA defended it badly in my lifetime. I immediately, so when they started defending it, I said, why are you defending mercury? It's a heavy metal. It's like, the ADA did that, and the ADA came up and they made facial pain a specialty, because all of these disparate symptoms, they say each one of them is a separate disease, and we need a specialist. That's not true. Any dentist who takes our course can do this. So I would throw out here also the statement that if you really want to find a dentist, get your dentist to take our course, which they can find on our online, and they can take an online course, be licensed to do this, provided to you as a service. Same thing that I do here, my associate does, and the other doctors who are licensed to do this in 20 states. Ben is also back talking about his opening is limited, and is that going to cause damage? Yeah. You have locking. Remember, the last symptom is locking, various kinds of locking, but patients who do this, they get open again. That would take another separate live stream. I'd be happy to put it on the list, all about locking of the jaw. Like, how do you get the jaw to lock? from inflammation in the joint? Well, it is direct, and I covered under my other podcasts. It's covered on the blog, how locking is associated with the meniscus or the disc in there, and the synovial fluid. The fluid has a lot to do with why a joint locks. If I do a job where I speak more but opening is limited, is that going to cause damage? Yeah, the more you use your jaw and the wider you open, if you go to the dentist, get your teeth cleaned, sing in church, yell at the dog, don't yell at your husband or your wife. The more you open widely, the more you're going to stir this up. I warn people about that all the time. Okay, and finally, Ben says, likely it has become arthritis now. Yeah, you have inflammations, arthritic changes. The chronic inflammation causes damage to the bone. You take an x-ray after 20 years, and now the bony features of that jaw joint are diminished. They're eaten away, literally degenerated because of the chronic inflammation within the temporomandibular joint. All right, so without further questions, and I do appreciate your questions, I am going to wrap it up here. I encourage you to come back next Saturday. Unless I'm traveling out of the city, I will be in my studio here and discuss TMD Demystified live stream. You can come back next Saturday. Be prepared to ask your questions. I appreciate the questions. And I will lead you one way or another to a solution. If you are a patient and have this problem, I can one way or another lead you to a solution for this disease. So until next time, I am Tony Urbanek, and this is TMD Demystified live stream.